Well, learn a lot, hopefully. It's some of my favorite topics. I love talking about optics, spherical aberration. A lot of my slides are from Dan Reinstein. He is amazing. He's my optics and surgical hero. Just taught me so much. I went out to his course last year in London, and a lot of this is from his teaching and philosophy. So let's get started. And we'll have time at the end for questions, hopefully. Make a difference in lens selection and outcome for the patients. Lens options, we'll talk about different optical mechanics, clinical outcomes data, and things to be aware of with each lens choice, and then post-operative care. So the big problem with presbyopes is it's a very it's a very prevalent problem, and it's very difficult to treat. The question is not whether to address it, it's how to do so without compromising or sacrificing optical quality. So you all know we have 20 diopters of accommodation at age 10, and we only have 2 diopters by age 50. So we have this dramatic decline in our 40s, and 32% of the world is 45 or older in 2026. 99% are presbyopic. So this is a huge problem. Why is it so difficult to approach? Well, this is the main issue. There's so much that's being thrown at it. There's light, there's HOAs, higher order aberrations, glare and night symptoms start. I had a 38-year-old today with level 2 dysfunctional lens, also a latent hyperope. And it is a real thing, a real frustrating thing. So this is when things kind of start to go downhill. And then visually significant cataract is level 3 of dysfunctional lens syndrome. Everyone, hears that. I think that is kind of an antiquated way of thinking. I think more along the lines of how is the patient's lifestyle impacted by what's going on with their eyes and their vision. If they have complaints, if they're struggling, if they're not able to do the things they like to do, and they're 43, 48, 52, of course, and I'll talk about a little bit later the risks of high myopes and not having a PVD and that kind of thing. You have to take it all into consideration, but there is definitely an opportunity there to help the patient. So we talked a little bit about this, but a well-planned custom lens replacement can achieve distance vision, intermediate vision, close-up, and long-term protection from cataracts. A lot of patients love that benefit, that they won't ever develop a cataract. And then they get a lot of use out of the specialty implant. So same thing said, kind of a different way. Treat the lens now and instead of waiting till it's a real problem. And a lot of the patients avoid getting the cataract, and then they have a lot of extra years of having this special lens. So they get a lot of bang for their buck, so to speak. So what are the steps? Just like any cataract surgery, we have an in-office surgical suite here at Shore Vision. So we often actually offer bilateral same-day surgery. It's very quick. It takes about 6 minutes to do each eye, with of course the turnover in between. We treat each eye as a totally separate surgery. So we start from scratch, take down all the drapes, clean the room, and then sterilize the second eye and open up a whole new set of equipment. We do treat with Valium for a sedative. They don't really need much else. 5 milligrams of Valium goes a surprisingly long way. I think we've been over-treating patients in the surgical center for a long time. I was amazed that this actually works in the surgical suite setting, but patients really don't need much, and they're comfortable and they're cooperative. So it's really, really nice. If patients are struggling with that or have claustrophobia, you can give an MKO melt under the tongue, and that really helps as well. That has ketamine in it. So we do microincision, capsulorhexis, phacoemulsification, lens implant, and a self-sealing close. And I'd love to show you videos, but we got to talk about optics. So that's for another lecture. But we have amazing technology here. We just got the Artivo 850 with a heads-up display. So family members can watch with their 3D glasses. It's really, really cool. And then we have the Alcon Unity, which is a new phaco machine, which is awesome. It's very, very, it's worth it. It's like super stable. It's just amazing fluidics, and I'm enjoying it. So we offer both eye same day. It's really nice for patients. We do this for cataract as well. It's nice because they can get both eyes done. It's a quick drop program afterwards, very efficient. Patients, use the same drops in both eyes. There's no time period where there's anisometropia between the eyes. I do also have the LASIK lasers, so if we do miss the target, I can optimize them in the office. So that's easy, but I really like offering this to patients, and I think it takes a lot. It's a relief for patients when they can just take care of everything on the same day. So what is the recovery and drop timeline? It's the same as cataracts. I always tell them the day of surgery, they'll be a little steamy and foggy, the vision wise, especially if they came from somewhere like emmetropia or they had a small correction and we're just really addressing the presbyopia. They're not used to this other technology in their eyes. So I always tell them that they might have worse vision just for a day or two than they're used to, and then things will click into place. And then they start using combination eye drops. We send them home with 4 times a day, and things start to really kind of click into place over time, and their brain neuro adapts depending on what lens they have. By month 1, they're pretty much stable, and light adjustments can start for the LAL. Contraindications, any refractive instability, you have to have a stable prescription for 1 to 2 years. For obvious reasons. You don't want to put an implant in and then have things change on you. Ocular pathology, any significant retinal disease, macular degeneration, corneal ectasia. If the ectasia is stable, you can do a CLR, and I've done that quite a bit, where I've corrected their myopia and astigmatism, but you've got to stabilize that ectasia first. Glaucoma, you really want to be aware of contrast insensitivity with some of these lenses. So you really have to understand the whole eye and what's going on before proceeding. And then unrealistic expectations. Some of these patients come in wanting to see everything, and they don't want to hear about the downsides of a particular lens. So you really have to coach these patients. Otherwise, you're going to be regretting it. So I've said no to a lot of patients, actually, and some friends and family friends and people I have relationships with. I've said, I can't help you. And that's just as important as proceeding with surgery and figuring out what lens to put into a different patient. But saying no and recognizing when you can't help someone, that is super, super important in this field. You don't want to make someone worse. So risk of complications, of course, with any intraocular surgery, there's infection risk, endophthalmitis 0.03%. Macular edema can happen, swelling in the retina, suprachoroidal hemorrhage, exceedingly rare, but it can happen. And retinal detachment is the big one that we think about, especially with these young eyes who are myopic. So I'll talk more about the retinal detachment on the next slide, but think about it as about 2% risk. And then, of course, PCO, or capsular opacification with the YAG. Just know that PCO is very, very common. I never say it's rare. It occurs in 20 to 40% of patients with any intraocular implant. I always polish the capsule after, and that does help. But this is just something that is a sequelae to surgery. And I always say, if your vision changes and gets blurry, or you start to develop glare, you may have a membrane on the lens. And that's a super easy fix with a laser procedure that's covered by insurance. So it's really important to coach patients. It's not a failure of the surgery, but it's just a natural progression where those epithelial cells migrate. That's what they do. So there's microscopic cells, and they just grow across the backside of that lens. And when the patients understand, it's not scary. They just want to know that their surgery didn't fail. So this is a study from the ESCRS MyoPred study, and it's really interesting. It just shows you the importance of identifying a PVD, posterior vitreous detachment, on all patients. So I check an OCT on everyone and have a lot of relief if they do have a PVD. So this just shows you that an axial length of less than 25, they have 1% risk of an RD at 5 years. And if they have over 25 millimeters, their risk is 0.5% if they do have a PVD, and 5% if there's no PVD. So that's quite a big difference. Just that vitreous loosening up and liquefied and in the middle of the eyeball just takes off a lot of the risk with these surgeries. So it's essential to determine, I always mention it in my operative plans and that's something I never skip. And this is really from Dan Reinstein. So measure first. This just talks about pre-op testing. This is, I find, a really fun part of the patient experience. We have a lot of amazing technology at Shore Vision. So we got the MS-39 and the Osiris, which MS-39 is a tomographer, and the Osiris is whole eye aberrometry. I'll show you some pictures later. But these devices make all the difference. Being able to see and understand the cornea and the eye and what the light is doing inside and out is a game changer. And there's no more guessing. There's no more fear. That coupled with Dan Reinstein's binocular blended vision tolerance test and his refraction technique, I really feel going into these surgeries that I understand the patient and the eyes so much more than in my past life. So it's really, really cool. I'm happy to talk about these diagnostic devices with anyone. We do have the first Osiris in the US and the first MS-39 in Nevada, and I think one of the first in the country. So they were just approved here, but they've been using them in Europe for quite a while. And I'll show you why those are so special. But essentially, MS-39 has, the Pentacam has 10,000 data points, and the MS-39 has 40,000. So it allows you to really visualize everything going on in the eyeball. It's pretty amazing. So you really want to fix the tear film first, because a dry eye can throw off the keratometry in an unbelievable way. So it can look like keratoconus. It can look like 0.6 microns of coma, but it's not necessarily real. So if they're dry and they've got a scratchy cornea, you really have to optimize that before proceeding. So I'll place plugs, I'll start MIBO, drops, everything before I even take measurements. Well, I'll take measurements, but then toss them because it does not count. So really, really important to control dry eye, and I'll work with a lot of my optometrist colleagues to get that lined up before proceeding with surgery. So the cornea is super important. We like to measure the corneal spherical aberration before choosing any lens. The aberration is the guide, and I'll show you how to think about this in a few slides. But the goal, a lot of the thinking has in the past been to zero out the spherical aberration. A lot of the lenses have a spherical aberration of minus 0.27, and that's because the corneal is a plus 0.27. And so the two kind of average out to zero. But a lot of the recent studies and research have shown that spherical aberration is actually a tool, and it gives us depth of focus. So we don't actually want to zero that out. We want to use it to our advantage. So the normal cornea is plus 0.27. Most IOLs are designed to compensate for this. Post-myopic LASIK, you're flattening the central cornea, so they have a positive SA. The light moves further back. And then the post-hyperopic corneas have a negative SA. So you don't want to put a Johnson & Johnson lens with a negative SA on top of a post-hyperopic LASIK treatment, because they'll get too negative. So just some things to think about when choosing your lens. So this is just a patient of mine with a printout of the MS-39. I just wanted to show you the magic. So it looks a lot like a Pentacam, but these numbers are great. And there's other printouts and things you can play with. But essentially, you can look at the refractive analysis, the amount of coma. This is plus 0.62, spherical aberration minus 0.20. You can look at the distance between the limbus and the pupil center. A lot of great information. This is the Osiris. And so this is whole eye aberrometry. This is the pupil right here. So this is looking through the pupil and looking at the wavefront, what the light is doing when it bounces in and out of the eye. So if I had you guys live, I would ask you what these rings are. And a bunch of you would probably tell me it's a diffractive multifocal lens. So you can see the power of the rings of these lenses. So I have another slide where I'll show you some of the different, but you can see how cool this is for a refractive surgeon to be able to see what the patient is seeing. So I had a patient today with a floater. I could see that on this wave scan. I had a cataract that was a wedge shaped with a bunch of water vacuoles, and you can see that. It's so cool. You can see a wrinkle in the capsule. So this is just like so powerful to me, both for my decision about what to do with the patient and also for patient education. So this is just like the tip of the iceberg with the Osiris. It's just amazing. And these are all the higher order aberrations. So you've got spherical, and this is whole eye aberrations versus the other, which is corneal. So this one's coma, 0.12, and then it goes way high, like trefoil and all the different crazy high order aberrations. So that's just pretty cool. I nerd out on that machine all the time. These are other measurements that we look at: angle alpha, distance between the visual axis and the optical center of the lens. We look at the chord mu, which is the pupil center to the vertex distance, just a different way of looking at that same number. The pupil size, which the Osiris also gives us in different lighting. So if you look at a large mesopic pupil at night, super large pupil, 7 millimeters, that will expose the peripheral cornea and give them more HOAs at night. So you really want to look at the pupil size in different lighting conditions when thinking about lenses. But really, this is a new one. Angle kappa does not predict multifocal outcomes. I always grew up looking at this, like in training and everything, but there's been some studies recently that show there's no meaningful correlation. So I do look at it, but I'm looking more at chord mu, angle alpha. Angle kappa has kind of fallen out of popularity. So the eye narrows the menu, and then the patient picks from what remains. So always look at the eye, and then you have to talk to the patient. So talk about visual goals, night driving demands, personality, tolerance for halos, tolerance for readers. Like if somebody tells me, I don't care about halos, I just want really good binocular tiny print reading vision, I'll reach for a multifocal for sure. It just depends on the patient. If they're young and they just do not want any compromise in their visual quality at any expense, then I reach for other options, which we'll talk about. So I'll always talk to the patient. We don't see medical patients here at Shore Vision. So we basically just see surgical evals and post-ops and surgeries. So it allows us to have more time to spend with these patients. So we end up spending 60 to 90 minutes just on the consult day. And I can really use that time to explain their eyes, explain their imaging, and then understand, what the best solution is for each patient. So it's really nice. We always treat astigmatism. Even 0.75 of residual silk can throw off a lens optics. So it's not optional. We really kind of push this home. We want the lens to perform well for the patient, so we don't want to leave this. So we'll do an LRI or a toric if they have over a diopter of astigmatism. And we have a really cool technology for this. Our IOL Master connects with our microscope. So we use the Callisto. So basically, the IOL Master captures features of the patient's conjunctiva and their blood vessels, and then we can line up with an overlay, which you can see on the right-hand side here. We can line up the toric lens in the axis of their astigmatism real time. So it's really, really cool. It's not the what is it called? The Aura. It's different. It's just real time. It links to the patient's actual anatomy. So it's very cool. And we have this heads-up display right here. So as you all know, post-refractive eyes are the hardest to hit the nail on the head in terms of predictability. The modern formulas are very reliable. 85 to 90% of patients are within a half a diopter of the expected refractions for normal patients, but in LASIK eyes, that drops down to 65 to 70%. I think this number is a little bit low. I think the new IOL Master 700 is awesome, and we have great formulas, but you have to believe the data. So that's why the light adjustable is nice, and we'll talk about that in a little bit. The optics behind the choice. Okay, this is the fun stuff. So we use spherical aberration and depth of focus really as a tool. So we talked a little bit about this, but I'll just talk about what this is. So an aspheric lens, the central rays focus So the central rays and peripheral rays focus on the same point. So there's the same angle of incidence of incoming light. But in a spherical lens with spherical aberration, you have the peripheral rays and the central rays behaving differently. So you have, in this case, the peripheral rays are focusing anteriorly to the central rays. So that's positive spherical aberration. And that gives you, this right here gives you the depth of field. So you have the anterior and the posterior focal points, and that's the whole range of what the patient can see. So you can see why this is a really nice tool. And this is just showing you without spherical aberration, you can see really one focal point, and then with, you can have this kind of range of where you can see pretty well. And the brain kind of takes these three images together and gives you a nice clear one. So this is the Zernike polynomial pyramid. You've all seen this. This is basically the optical path difference or wavefront error of the light. So it just describes the pattern. Instead of being a sphere, for example, this is spherical aberration where the Zernike 4, where the peripheral rays are focusing differently than the central rays. So it just describes the shape of that light. And this shows you that when you're reading, when you're up close, if you have minus a diopter and a half of defocus, plus you're reading up close, your pupil accommodates. When you're accommodating, your pupil shrinks to 4 millimeters, and then you add in the spherical aberration. Those two things combined, you have a nice clear image with neural processing. So the eye and the defocus kind of work together to give you that reading, the nice crisp reading vision. And this is a study, this is also from Reinstein's slide, he put this together, but this researcher, Dr. Roca, identified that depth of field increases with both negative and positive SA. So you can have this whole range. You have a 2 diopter depth of field with up to 0.6 of SA, positive and negative direction. So there is a therapeutic window where you can kind of aim with your calculations, and I'll walk you through that. But it's toxic if you get over 0.6 positive or negative of SA, but there is a therapeutic window where you have this nice range of vision. So the strategy is select a lens that achieves the desired sweet spot. So with the Osiris, we can look at ocular SA, higher order aberrations, corneal, and internal. So basically, we want to pick a lens that brings us into that zone. So internal is the lens SA, and then corneal is obviously on the cornea, and ocular is whole eye. So think about it like ocular equals corneal plus internal to figure out that target zone. So all the lenses have different SAs built in. So every patient that I pre-op, I'm doing a calculation to figure out where I want them to be after surgery. So we want 0.3 to 0.6 basically. I don't typically aim for 0.6. I usually aim closer to 0.3, but I'm happy anywhere in between. But you've got negative SAIOLs like the Alcon lenses and the Johnson & Johnson. You've got neutral lenses like Bausch & Lomb and the Acryos. And then you've got lenses with positive SA. So if you have a negative SA like post-myopic LASIK and you want to bring them up more in the positive direction, you will use this like SA60 AT, which is an old lens, but it works really well. And then the Zeiss C2 Lucia works great too. So the lens menu, let's talk about lenses. There's a lot of different options, one decision to make. So this is where it's kind of fun putting it all together. We've got a diffractive trifocal. This diffracts and splits the lights into different focal points. We've got non-diffractive EDOF, extended depth of focus lenses. We've got enhanced monofocals, small aperture lenses, and adjustable power lenses, which actually have some EDOF effect for the light adjustable. But it's important to understand these lenses because they all kind of go into our toolbox when we're selecting something for the patients. So first, we just really have to understand a defocus curve. This is how to interpret what the lens achieves. So it's better than, really understanding a defocus curve is better than reading the pamphlets from the lens companies. The lens manufacturers have an objective. They produce great products, but you really, really have to understand the lens optics for yourself because, you've got to make your own decisions. Another cool thing about the Osiris is you can look at the defocus curve for each particular patient. So you can run the machine and then actually look at their defocus curve. So once you implant, let's say, an EDOF lens, you can see, did we achieve what we were trying to achieve? You don't have to take the lens manufacturer's word for it or the patient's word for it. You can say, look, you can see 2032 at intermediate. So how to read this is distance or 0, and then you've got the acuity on this y-axis. So distance, then -1 is intermediate, -2 is near, so this is near. So you've got a monofocal lens has one peak. You've got an EDOF with this orange, with this broad shoulder, so that you can see pretty much 20/20 drops down to like 20/25 at -1, -150 intermediate, and then -2, like really near, you're getting down to like 20/40. So it's a little bit declined at the close-up, which is why we'll talk about offsets later on. And then the trifocal with these 3 peaks at distance, intermediate, and close-up. So they have this dip. The dips are where the patients complain. You have distance, and then a dip, and then you have a 20/25 at 150, and then a dip, and then you have, again, good vision at near. The in-betweens are where patients get frustrated, which is why the EDOF is nice, because there's not a huge dip in that. This is another way of looking at the lens functions. So it's the light distribution. So you've got the monofocal, which is infinity. You've got a synergy multifocal with those 3 spots of intensity. The PanOptix, same thing. You've got a little bit more merged at the intermediate and near. And then the Vivity, which is an EDOF, kind of an EDOF light lens. It does have some diffraction, but the Vivity is down here. So you've got up to like a -150 with that Vivity lens. So let's talk about some of these individually. The enhanced monofocal, J&J's Eyehance is a good example. It's basically a monofocal lens, so it's not a premium lens. You can't upcharge for it or anything, but it's a great lens. It's oftentimes my go-to just distance lens, but it does have some built-in spherical aberration centrally, and so it's really nice. It gives you about 0.2, 0.3 of depth of focus. So they just have this surprise, oh, I can actually read a little bit of intermediate without my glasses, or the text will just check the near vision and they're surprised that they're a J2, J3, J4. So it does give them a little something, a little boost. And this just shows you that at the intermediate right here, they're not 20/40, they're 20/32. So it does give them some functional intermediate vision. EDOF is that stretch strategy. So it stretches the light from distance to intermediate or whatever focal point you're aiming for. But it's a really nice option, especially for people who don't want any compromise in night driving. There's no light splitting. So the dysphotopsia profile is much kinder, much gentler. And I always do a little offset to the non-dominant eye, or not always, but often, to give them a little bit more range. EDOF lenses, PureSee is the newest, latest, and greatest. It's really amazing. So it just got approved in the US not too long ago, I think in March. And it's hard to get now because everybody's jumping on the bandwagon, but it's a great lens. It's much kinder to contrast and sensitivity, but and patients love it. It's really, really a great option for blended vision, which I'll talk about shortly. So it gives you excellent distance, intermediate, some near. So I'll talk to you about offsetting, but essentially I offset the non-dominant eye by 1/2 diopter or -3/4. And it just gives the patient distance and intermediate vision in the distance eye, intermediate to near in the near eye. And there's overlap and the eyes work together, and it's a great option. This is the PureSee. It's actually interesting because the center of the lens has negative SA, 0.65, and then the periphery of that lens, and this is again through the pupil, has plus SA. So it's kind of an interesting design optically. And this just talks about in the little impact on contrast and sensitivity. This is the trifocal. I don't mean to bash the trifocal. I love this lens for certain patients. And this patient yesterday said I was a genius because I implanted the PanOptix Pro, and he just like needed his close-up vision to be great. and he's absolutely in love with this lens. And I told him, you will have rings of light at night. You will have rings around street lights. It's annoying, but it's a thing to expect. He is so happy he went with this lens. So it's a great option. You just have to be selective in who you're going to implant it, and you have to educate, but it's a really great option. And you can see here, this is why it's such a great option. Both eyes just have good vision at distance, intermediate, close up. Small aperture lenses, I don't have a ton of experience with them. I don't usually reach for them, but they are good if in need. Like a post-RK eye with crazy irregularities, it's kind of like a pinhole effect. So it gives the non-dominant eye some reading, and it blocks some of those irregular light rays. So it is a good option, but it's not like my go-to. It's a little harder to YAG. This is cool. Again, Osiris is amazing. So you can see these light rings with the different, you can see the pattern of the different lens options. So multifocals, here you have the Vivity lens. So you can see this negative power here, and then this positive power. This kind of looks a little bit diffractive to me, but it's an EDOF technically. This is the PureSee, where you've got the power centrally, and then the less power peripherally. So that's just very cool to me. Back to the lack of predictability with post LASIK eyes. Of course, these patients are the ones who really want you to get it right, and they want to be out of glasses. So this is the most common patients that we see, but they're also sometimes the most difficult to hit the nail on the head. So there are, and thanks to RxSight for sponsoring this talk, but we got to talk about LALs, which are great. I actually went to their headquarters last year as well and saw these lenses being manufactured, saw the LDD machines being manufactured. It's amazing. It's an amazing enterprise, an amazing technology. So we're really lucky to have it. So this just talks about how you can, for the tough targets to hit, this is a great option. You do have to, after surgery, patients have a lot of work to do, as do the clinicians. So you implant the lens, you use your same power calculations for the lens implant, and then afterwards you do up to 3 treatments and 2 lock-ins to get the refraction to where the patient wants it to be. So it is some work on both parties, but it's worth it for some patients who want to test drive their vision. They want to maybe try intermediate, and then they say, oh, you know what? I really want this font that's on my watch, like the big font on the watch. And then you can plug in a little more near in their non-dominant eye. I once had a patient who actually reversed, before I did Reinstein's 4 methods of ocular dominance, which I do now for every patient. I didn't realize the patient had mixed dominance. So because I just checked it one way, and after his light adjustable lenses, he realized he wanted the other eye to be his dominant eye. So we switched it, and he was super happy. So that was a luxury that I didn't have to do a lens exchange for him. But now I check dominance 4 different ways for everybody. So light treatment after implantation is pretty cool. You have an active shield on the outside of this lens. Then you aim, so that protects you if you're outside or by a window. You have to wear the glasses, but if the patient doesn't, there's a protective layer. The UV light shines through the lens. There's polymerization that happens. The lens changes shape, and then you lock in that shape that's your desired results. And this is the device. It's small. It's kind of the size of a YAG laser, but it's really reliable. The outcomes are amazing. Patients do great. And a lot of patients really want to be involved. And a lot of optometrists can do these treatments as well, so they can really have an active role in the patient's surgical journey. So it's a pretty cool opportunity. But you do have to talk to patients. You have to wear these thick, dark glasses for 6 weeks at least. RKIs you can do the treatments for up to like 3 months, so 3 to 6 months. So it is a process. You have to get great refractions, and it's a journey, but a lot of patients, it's worth it. So it's best for post-refractive corneas, perfectionist personalities, patients titrating blended vision as well. So let's talk a little bit about blended vision. This is kind of like the grand finale. This is my favorite technique these days. And a lot of this is I keep talking about him, Dan Reinstein. He does Presbyon, which uses blended vision. And essays in the cornea in his LASIK treatments, but he uses the principle of blended vision to achieve spectacle independence. And it really makes a lot of sense even for lens implants. The problem with monovision is that the eyes are not working together. There's a loss of stereo vision, reduced contrast. There's only 50% tolerance in patients, and that's not good enough for me. So I do a blended vision tolerance test, which we don't have time to get into, but I do this on every patient I'm doing blended vision for. And basically you can give them the full correction of like the 150 in their non-dominant eye and see if they tolerate it without them really knowing what's going on. And if they can't tolerate it, you back down until they're accepting it. So it's the acceptance test. It's really, really cool. I can talk more about it next time, but it's very helpful to have that tool in your pocket as well. So this is monovision. You've got the near eye at -2 and the distance eye at plano, and you've got this big gap in between. You've got the distance eye seeing 20/20 centrally, and then the near eye just totally suppressing everything to 2200. Blended vision, though, there's overlap. You've got the distance eye with the 20/20 and then the 20/63 around that, and then you've got the near eye that's seeing 20/63 at distance here. So there's overlap between those two. And you have a blend zone. So the non-dominant eye sees from distance to distance to intermediate, and then the distance eye sees from distance to intermediate. The near eye is intermediate to closer up, and there's a blend zone in the intermediate. So the eyes are both seeing intermediate, which is why you don't lose the stereo vision. So the eyes work really well together. So you've got that blend zone. So the principle is overlap, don't gap. There's 95% tolerance with this versus 50% with full monovision. So patients do really well. It takes my patients about a week and a half to like really start to not be kind of weirded out by the difference and the change. And then they start to it locks in, and their brain starts to take over and neuro adapt. So it's pretty cool. This just shows with the principle of monovision. So you've got these two peaks with a monofocal lens. With the extended depth of focus, you have each eye with this elongated peak. So you don't have those two totally separate eyes, separate vision. And so the eyes are just working more together. There's less disparity. And then this talks about the offset. So typically in the non-dominant eye, like I said, I'll offset by -0.5 or -0.75, depending on how important very good near if is for them. So I'll talk to them about it and show them the difference in the distance between if you offset them by -0.5, the impact of that on the distance vision. So this shows you the binocular vision and then each eye independently. So it works really, really well for patients, but I always plug it in ahead of time so that they can try it out. So after the surgery, basically, if a patient's unhappy, don't panic. There's usually a solution. So get the refraction right. Residual error explains most complaints. I had a patient with half a diopter of hyperopia and like half a diopter of SIL, and we treated that with LASIK, and all of his complaints went away. He was a +0.5, -0.5. So it was really a small spherical equivalent, but it made a difference for him. Treat the surface. A lot of times the drops will disrupt their surface and their quality of vision. Evaluate the capsule for PCO, and then really give neuroadaptation 3 to 6 months, depending on the brain and the patient. Some patients it clicks in right away, and some do need time to adapt to their new lens or new technology, whether it's a trifocal or EDOF or whatever it is. Give the patient some time before having an intervention. And then if you're doing these kinds of surgeries, you have to be comfortable with lens exchanges and laser and LASIK touch-ups. You really, really have to be able to follow the patient all the way through to the end point. You can't just put the lens in and then say, you're fine, you'll get used to it. You gotta get them to the end. So we give patients the combo drops, weekly taper, watch for PCO. We see them at day one. We actually do see them at post-op week 1, and then they return to their OD for their full visit and refraction dilation. So this is our team. We've got our trainers who are accrediting our OBS in the back, and then my staff. We've got 2 techs who are my clinic techs, and also they wear 2 hats. Kylie is my scrub tech, and Jenny is my circulator, and they're learning their new roles. They're awesome. And then Andrew is our practice manager, who is also our pre-post nurse. So he's doing a great job there. So it's really, really fun working with them, and the patients know them really well from their clinic experience, and then feel so comfortable having the same team in the OBS. So that's another nice reason to have in-office surgical suite. And then this is our surgical suite. You can see this big glass wall. We do have a shade that comes down if patients want privacy, but it's pretty cool that we also have the family can watch in these little nooks. So this is my friend who had a custom lens replacement last week, and his parents got to watch. His mom has the 3D glasses on, and they were all loving it. It was pretty fun. So this is us operating with a 3D microscope, which I kind of am toggling back and forth, but it's really cool. It does take some getting used to looking away from the scope, but it's amazing. You can see so much detail there. So that's all I got. I'd love to open it up to questions. I know it's a lot of optics and kind of some crazy higher level stuff, but thank you all for listening.
Thank you. We have a lot of questions coming in, so keep those questions coming in. I'm going to kind of look at what comes up a lot. When you check for dominance, what do you do if the tests disagree?
So that's a good question. So I do four dominance tests, and I'm happy to share, but it's basically a camera, a gun, which one patient, it's like a handgun, but one patient brought it up like a rifle. It was pretty funny today. The hole in the card, and then the pointing. And if they do have disagreement, what I do is during the blended vision tolerance test, what you do essentially is you put the ret lenses in front of both eyes. So you're checking binocular balance. The ret lenses are up. In front of the non-dominant eye, you take away non-dominant eye, you keep the ret lens. Dominant eye, you take it away. Then you show them the distance screen, you show them the near card. You show them the distance screen, you show them the near card. And then you say, is that weird, basically? If it's not weird, okay, great. Then you say, all right, you switch it around. So you make the dominant eye, put the ret in front of the dominant eye, and then open up the non-dominant eye. So you're switching. You're basically reversing. You go back and forth. Say, which is weirder? So if they have cross dominance, I always run that test. Is it weirder with the left eye being close up, or the right eye being close up? So you toggle back and forth, and then you can really iron out which is less weird for the patient. You can also do a time to suppression test, which basically you put the ret lens in front of the non-dominant eye, and you basically have them clock how long it takes the brain to deal with that, to adapt to having that lens in front of that eye. And then you switch it. How long does it take for the brain to adapt? They can clock it and say, okay, this one is quicker at adjusting, if that makes sense.
Would you be able to go through the dominance test? That's probably the most common question I'm seeing. People are very interested in hearing. We have our ways of doing it, but I think people are very interested to hear how you do it.
Yeah, I know. It's like it seems like such a basic thing, but it is so important. And actually patients have a lot of fun with it. So, and this is all from Dan Reinstein. So basically, first thing I do is have them, the typical thing, either the triangle or point. That's number one. Then we have a little plastic camera from Amazon and say, okay, get that O and take a picture of the O. They put it up to one of their eyes. That's another one. And then we just write gun, right eye, camera, right eye. And then there's a hole in a card. So you have them capture that. And then what's the other one? And then the point. So there's the hole, they get the hole in the middle, and then you're like, okay, which is it still in the center of the hole with the right eye covered or the left eye covered? So you can tell which eye they're looking at. So have them hold it straight out. And then the last one is point to that letter. And then you have them close each eye, which eye is actually seeing it. So it's just, you run down that list every time. My techs are really well trained now, and they just write it in the HPI. So they write 4 out of 4 right eye dominant or cross dominance. And then, yeah, that's what we do.
Thank you. That was by far the number one question. Was that what you were expecting? That was people are very excited. Very interesting. Let's see. Oh, and the other question is, when it's time, what lens will you choose? We were waiting to hear your choice.
Yes, good question. 1 billion person, I would, not 1 billion, but I would definitely PRC. I'm like in love with this lens. It is so forgiving. It's so gentle. And then based on how you offset that non-dominant eye, like you can really capture the whole range of vision, and without having any of the negative things with like a multifocal or the rings or the contrast. So I think it's like definitely, like, I'm really, really impressed with the results, and just so grateful that we have this lens finally. So I would do PRC, or I'd go to London and do the Presbyon with Dr. Reinstein, but I'd probably just do the CLR and avoid having a cataract, especially because I'm hypro.
Let me see. For the same day bilateral cataract patients, does their insurance cover the second eye, or are they charged completely out of pocket?
So insurance pays us, they're covered if they just do like a basic lens. Insurance pays us half on the second eye. So we take a cut, but for us it's worth it, just to help the patients. And it's just a nice thing to be able to offer. And the patient, it's now that we've done them for a month, it's really nice to offer that. I can't imagine going back to like having to space them out by 2-3 weeks in a month and having to deal with the drop schedules. So we don't mind the cut. Also, we do, we mind it, but it's a good thing. But also we do charge a convenience fee for like their post-op kit. We do lubricating drops. We do the Imprimis combo drops. We do, we're available on Clara 24/7. So like we do charge the convenience fee if they're just a basic lens to cover, help cover some of our expenses, but it's not prohibitive.
Let's see. Can LAL patients wear UV blocking contact lenses instead of sunglasses?
Good question. I have not heard that before, but I would think not, because you don't want those peripheral rays to come through. You really want to just cover as much as possible, because the UV is what's treating the lens. And the studies have only shown like the glasses that come around block the light. So you just don't want to take that risk that you'll use up your treatments because the patient wanted to wear contacts. Like, you just don't want to go there. If they want to do the LAL, they have to commit.
How do you ID LAL lenses on slit lamp? How would we know that a patient's had that done? Because they don't usually know, right?
You can't tell the difference. When we're implanting or explanting, it's definitely a thicker lens. It's a little more brittle when you're explanting, but you can't tell just from looking at it. You have to ask the patient or the surgeon, get the op report, but there's nothing identifiable. It's a 3-piece lens. That's one thing, one clue. So you'll see the blue haptics, but there's nothing else about the optic itself.
How do refractions work with LAL lenses? Can you still prescribe glasses if they need for distance or reading?
Oh yeah, absolutely. The purpose of the treatment, of the adjustments, is just to get to your final endpoint. So think about it as any lens-based surgery, cataract or custom lens replacement. You're putting a lens in, and then they have a final resting point refractively, so then you can give them glasses, contacts. It's just like that. So basically, after the treatments and lock-ins are done, that's it. They're just like any other lens patient. They've just had that flexibility in the treatments.
If a patient has blended monovision and is being prescribed night driving glasses, is it okay to prescribe the full RX, or should it be slightly reduced so as not to break their adaptation?
Their adaptation is not threatened. So basically, their eyes are working together because of the nature of blended vision. So nothing you can do can disrupt that. So if they have night vision complaints, their complaints are because of the myopia, or the pupil size, the peripheral aberration. So definitely correct it fully. You're not going to cause any problems. Just correct the patient's symptoms.
Let's see, it looks like we probably have time for one or two more. Why are 2 lock-ins required with LAL lenses instead of 1?
That's a good question. That's just how the studies are. With one lock-in, there's always a risk that you might go outside and the lens could further change. So they've just proven with all their research that you just need 2 lock-ins, period. So the first one does most of the work to kind of freeze things, and then the second it uses up the rest of like the monomers that are kind of reorganizing with the treatment. So it's just like it exhausts the potential for more movement of those monomers. I don't know if I said that right, but I think so.
Let's see. I'll do one more. When you say trifocals, is it truly a trifocal or is it a multifocal?
It's a diffractive lens. Oh, did that go away?
The third switch in the screens are good.
It is. It's not really. Well, you saw a trifocal, like 3 points on that defocus curve, but really the ring the lens has multiple rings. Each ring diffracts the light in a different focal point. So it's kind of it's I would call it more multifocal because it's multi points. But to the patient, if you're explaining it to the patient, they understand distance, intermediate, up close. So functionally, I think that's more important for explaining these things to patients. It'll give you those 3 focal points really well.
Well, with that, I want to thank you. I know there are questions we didn't get to. That's always the sign of a good lecture, that more questions are coming up as we're answering. So thank you for being here. Thank you for spending your evening with us. And I think that gives us so much information that we can take back to our patients tomorrow. So also thank you to RxSight for supporting this event with an educational grant. Here is, oops, sorry, hold on. There we go. All right. There is the QR code. Don't worry, it's staying on this time. So thank you to everybody who joined us tonight. Make sure that you are visiting WooU to find out when the next event is. Make sure you're registered. And with that, I will say good night to everyone. Have a wonderful evening, and thanks for joining us. Take care.
Thank you. Thanks, everybody.